Hi, this is Brian Kim. I want to share with you case number 222 in the Best Way to Do Cataract Surgery series. This is a patient with about a 2+ dense lens. You're going to see double chop, cross chop, mechanical fracturing techniques, and how I disassemble the lens and reduce CDE and achieve clear corneas post-op day 1. But the point of this video is to discuss reverse pupillary block. Reverse pupillary block occurs because of relative zonular laxity, which can happen in the case of high myopes, but this can happen in any type of situation. And what you'll see in this case is a patient with significant reverse pupillary block and how I'm able to address it at the end of the case. So this is a corneal marker which will help me to center and size the rhexis. And I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is my incision for my hydrus. I'm actually not going to show the hydrus portion of this case because that is not the emphasis of why I'm sharing this video. But you want to make sure you achieve a nice shelf when you make your incisions, which will allow you to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. You can see immediately how big the pupil gets. And this patient is a high myope. And so as the pupil gets huge, that means the lens is being bowed back posteriorly as well. Again, the sign of relative zonular laxity, which is causing that iris and lens to get bowed backward. I puncture the center with the rhexis forceps, and then I grab the right side of the tear. I go around circumferentially, and you can see the stria in the cornea, which is a sign in high myopes. When you have a high myope, they tend to have thinner sclera, and the cornea tends to be a little bit more floppy. With these maneuvers, you can get some more corneal stria. Again, all of this is consistent with an eye that's like this. Again, I'm using that corneal mark that I made to help guide the size and centration of the rhexis. Burp some viscoelastic out. And this is the capsule fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress the bag. Sweeping under the rhexis edge under the left side and then the right side, and then the lens begins to spin. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. As soon as I activate the fluid, look at that reverse pupillary block. So I use a chopper to lift the edge of the iris, disengage the reverse pupillary block. I place a chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, surrounding the lens with the instruments, bringing the instruments together, crushing the lens in half. That is double chop. I place a chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally towards the phaco tip and crushing the lens against the phaco tip, and that is the cross chop. Using a little bit of vacuum and then placing the chopper around the lens, hooking the peripheral lens, encouraging it out of the bag, crushing the lens between the instruments, and then emulsifying the lens pieces. By utilizing mechanical fracturing forces, I'm able to crush the lens into smaller and smaller pieces rather than using ultrasonic energy, again, thereby using less ultrasonic energy. I'm trying to separate that second quadrant from the rest of the lens, so I do another cross-chop maneuver in the fissure, separating the two pieces, placing the chopper around that second quadrant. Again, because of that reverse pupillary block, the lens is bowed back more, and so it's a little bit more deep. You're in a more vertical position to get after the lens. It's deeper within the bag. I was able to use the instruments to hook the lens up, crush the lens into smaller pieces, and then emulsify the lens pieces. turning the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, crushing it against the phaco tip, and another cross-chop maneuver, placing the chopper around the third quadrant, hooking the peripheral lens, crushing it between the instruments, and then emulsifying the lens piece. Using the chopper to loosen it up, and then grabbing the piece with some vacuum, pulling it out of the bag, and then emulsifying the last piece of that third quadrant. Placing the chopper around the fourth quadrant, hooking the peripheral lens, and then again cutting the lens with the chopper against the phaco tip. It's almost acting like a cheese wire, just cutting through the lens. But because the chopping block is the phaco tip, since it's in the way, I'm able to effectively crush the lens completely in half. Again, this is metal against metal. Of course, the lens will break when you apply a crushing force with metal against metal. So remove all the endonucleus now. All of it is out. There's some small fragments that are still left. Go ahead and eat that piece up. And now the endonucleus is out. I go after the epinucleus using some vacuum. And again, remember, this is a very deep bag, a big eye. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. As I go in with irrigation, you see immediately that reverse pupillary block gets activated, and I quickly place the INA tip underneath the iris, and I'm able to relieve the reverse pupillary block. So during the case, as long as you just lift the iris, you're able to disengage the reverse pupillary block. Again, why? Because the iris is being pushed against the capsule, and because it's pushed against the capsule, it basically creates two compartments, a front and a back, and that front compartment develops significant pressure, and it pushes back against the posterior compartment, and that's what causes the reverse pupillary block. So by lifting the iris, you basically are able to create fluid flow both ways, and it alleviates that reverse pupillary block. So I'm using IA to remove the remnants of the cortical material, which came out pretty quickly, and then I'm using the polish mode to polish the posterior capsule, as well as to remove any stubborn pieces of cortex within the bag. And so remember, throughout this case, this patient had moments of reverse pupillary block, but was able to recognize it early, and I'm able to make sure that the patient doesn't have any discomfort. Throughout the case, the patient's doing very well, not really having any trouble at all. Remember, early recognition of reverse pupillary block is important, so you can reduce the chances of that happening, and if it does, being able to recognize it and address it immediately. So filling the eye with cohesive viscoelastic, and then using the sweep to sweep under the rexus edge, first on the left side and then the right side. And when you're dealing with cases like this, the bag is so far back, and you saw I was able to disassemble the lens very effectively using mechanical fracturing forces, double chop, cross chop. And why is that? Because even though it's deep and I have to put the instruments down, it doesn't affect me. It doesn't affect my ability to access the lens. I'm able to still disassemble the lens confidently, even though I'm turning the instruments down and I'm working deeper in a hole. It doesn't affect how I do the surgery because I'm utilizing mechanical fracturing forces to help me. So again, after I put the lens in, I activate the irrigation, and lo and behold, reverse pupillary block occurs again, and I quickly use the INA handpiece to lift the iris, and I'm able to alleviate that reverse pupillary block. I get underneath the lens, removing all the viscoelastic within the bag, polishing underneath the rexus edge. There's some fine lens material still within the bag. Go under it and start to remove that as well. Remove the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. You will see at the very end of the case, it's very important that as you hydrate your incisions, you will trigger a reverse pupillary block in some cases. And so what are you going to do? You can't just leave the patient in reverse pupillary block. That can cause significant discomfort. And so what I like to do is use a cannula to alleviate the reverse pupillary block. So you're going to see what I mean here. So I'm done with IA. I place the cannula into the anterior chamber. I come out with the IA. I push BSS to fill the chamber, and I quickly start to hydrate my incisions. I try not to let the eye collapse throughout the case, and that's why I have that cannula in. Again, this is my standard technique. None of this is out of the ordinary. This is my routine technique. I start to hydrate the incisions. But remember this, as I hydrate the incision, so you see I'm hydrating the hydrous incision as well. Again, I edited that part out. You don't really need to see that. But as I'm hydrating my incisions and I start to increase the pressure to physiologic, look what happens. As I push the BSS, you have sudden reverse pupillary block. This patient's feeling some of that. You see her kind of squeezing the eye. And so you don't want to leave it that way. This is another reason why you shouldn't place the toric lens in this configuration, because in my opinion, this may also cause the lens to rotate out of position. And so it's very important for you to be able to equilibrate both the front and the back and really disengage the reverse pupillary block. And this is how you do it. You place a cannula, a full cannula, underneath the iris, disengage reverse pupillary block. But this is the most important thing. You have to push vigorously with BSS as you come out of the eye. And you need to make sure that the eye is still at high pressure. You see here, the eye is really nice and firm, and I'm just gently releasing the fluid out of the eye. As you withdraw the cannula after you disengage reverse pupillary block, if you push BSS and you come out and the eye is soft, well, guess what? You have to fill it with more BSS, and then what happens? It triggers reverse pupillary block again. So you have to make sure you disengage reverse pupillary block by placing the cannula under the iris, and then you have to push vigorously with BSS as you withdraw the cannula, and you have to make sure that the pressure is still high. As the pressure is high, then you can gently titrate and burp BSS out of the incision until you have good pressure, and then you'll be at the end of the case. So I hope this was helpful to you, and I thank you for your attention.